So in reference to UIP diagnosis, we've had a couple of major changes in the last year to 2 years. So what we've seen is the Fleischner Society guidelines published in 2017 and then the ATS guidelines published in 2018, so just last year. And what these coalesce around is the idea that in patients who have a probable UIP pattern on their CAT scan, if you've done adequate clinical phenotyping of that patient and you've really excluded a known cause for that UIP pattern or that probable UIP pattern, you can render a diagnosis without a biopsy. So that's been a major advance that's occurred. Now, what we see in both sets of guidelines is the thought that if you're uncertain about whether there is a known cause for the ILD in the setting of a probable UIP pattern, then a surgical lung biopsy should be considered. And in that context, we have data published on a genomic classifier, the Envisia genomic classifier, that was published earlier this year in the Catalyst study. And what that study showed was that regardless of CAT scan pattern underlying, you could identify a UIP genomic signature with good confidence, and that held up in a multidisciplinary panel. So the upshot is, in those patients who have a probable or perhaps an indeterminate UIP CAT scan, you could consider using Envisia as a tool that helps you identify UIP or not UIP. And if it is UIP, then it gives you perhaps more confidence that you're dealing with an IPF diagnosis if you've done a good clinical history. A surgical lung biopsy is a procedure that we utilize in people with an unknown ILD diagnosis. We consider it in a probable UIP pattern. We do it, generally speaking, if there are not contraindications in indeterminate or an alternative diagnosis CAT scan pattern. However, we come across very frequently the patient who can't undergo these procedures because they have too many comorbidities or problems. So what do we do with that patient? And that's partially what this emerging diagnostic section addressed. The Envisia classifier helps to designate whether a patient has UIP or not UIP on a transbronchial lung biopsy by genomic signature. So it can be helpful in distinguishing those two processes in a binary fashion, but it has to be incorporated with clinical data. A UIP signature in the setting of autoimmune disease is still of unclear significance. So a UIP signature on an Envisia classifier in a patient who has idiopathic interstitial pneumonia is likely consistent with an IPF diagnosis, and that's where it can be helpful. A couple of the other techniques that were discussed are really quite fascinating. Endo Bronchial OCT that Dr. Lita Hariri discussed is a technique that really requires no tissue specimen biopsying whatsoever. So it's kind of the least risky of all the modalities that we have. It does involve bronchoscopy, but it involves serial imaging at a microscopic level with a probe that's placed through the bronchoscope. And in Dr. Hariri's studies, what she's shown is that you can identify pathologic features that correspond to fibroblastic foci and other features of UIP using this technique. So as it's developed, hopefully in the future, maybe 5 or 10 years down the road, we could use this technique in those patients who are not candidates for any type of biopsy at all. And then finally, Dr. Kulkarni discussed PET imaging, and she really showed a number of compelling slides utilizing different markers that are felt to be active in IPF pathogenesis and different cell types that are active in IPF pathogenesis. I think this is still at a fairly early stage. It's probably not just yet translatable to clinical practice, but it's an evolving area, and as she discussed, may help us guide therapeutics as well in the future. So cryo biopsy has had a lot of data published in the past few years. In just the past year, 2018 and 2019, we've had the coldest study as well as a study published in the Blue Journal looking at cryobiopsy versus surgical lung biopsy in ILD diagnosis. And they showed slightly different results with the knowledge that the coldest study, which was recently published, was slightly larger. Ultimately, the coldest study provided some security in the idea that cryobiopsy and surgical lung biopsy have diagnostic agreement, but of course it wasn't 100%. I think we have to bear in mind as we think about this topic that cryobiopsy is a nice option that's less invasive than surgical lung biopsy, has reasonable agreement with surgical lung biopsy, but at the same time requires really high level of expertise in our experience to implement. that there is a reasonable rate of complications such as bleeding, which was seen as well in the coldest study, as well as pneumothorax and other studies, that in at least one study published last year, the agreement with surgical lung biopsy is not quite as high. And finally, an element that I'll add from my personal experience is that in the studies of cryobiopsy that have been published, including the coldest study, patients were undergoing this procedure while they also were receiving their surgical lung biopsy, meaning they were receiving general anesthesia. So I think we have to bear in mind as we implement cryobiopsy in the world at large, are we going to be doing this routinely? When a patient undergoes cryobiopsy, will they always have general anesthesia as they did in the study when they were concurrently getting surgical lung biopsy? If so, are the risks really that much less than a surgical lung biopsy since you're subjecting them to general anesthesia anyway? So I think these that coupled with the bleeding complications have to really be borne in mind as we move forward with that procedure.